Hello, this is Emily Peters recording for Care the Growing Family, the Nutrition PowerPoint. I want to first off apologize for any noise you may hear in the background since I am recording from home. One of those noises you may hear my dog walking around. We have hardwood floors. All right, so let's get started. All right, so nutritional alterations. There's many factors that predispose infants and children to develop nutritional disturbances. The broader categories would be things like economic influences, things going on in our lives financially, social cultural influences, so cultural things, cultural diets to fasting. Fasting, very specific diets that may not allow for a wide range of foods. Geographic location, where we are in the country, and that can affect their access to foods, but it could also affect their access to sunlight. And then, of course, education. So that poor knowledge of what should be in a well-balanced diet, what is good alternatives for different ways people eat and cook, those kind of things. So some things that we see more commonly here in the United States would be with breastfeeding. Sometimes they will be deficient in vitamin D, and therefore sometimes we have to supplement with vitamin D for kids that are breastfed. Let's see, dark skin. Not only is this seen in the United States, but this is also seen in other locations, especially in Africa and places like that. Also places that have minimal sunlight. So things such as in Alaska, they do not get a lot of sunlight during certain times of the year. Like 22 to 23 hours of the day are without sun. And during those times of the year, if they are not getting that well-balanced diet that helps with the absorption of vitamin D, they actually may end up developing vitamin D deficiencies, which could possibly lead to things like rickets. We also could see this in areas like Seattle that are very rainy during some of the seasons. All right, let's see. These diets that would not have enough calcium and vitamin D, which we do see that here in the United States, not eating enough or drinking enough milk or calcium pertaining foods, smoking can affect your nutrition, especially on infants. In utero, they tend to be a little bit smaller if they're born to a smoking parent. As you've probably learned in Foundations 1 and Foundations 2, chronic illnesses can lead to nutritional alterations. Sickle cell disease, which we'll learn in Advanced Concepts of OB-Peds, can lead to some issues as well. I'm trying to think of some other areas in the United States where we might have some deficiencies. Lately, we've been having a lot of major disasters that can cause some nutritional alterations, especially if it is an extended amount of time that we are not able to get good nutrition to those areas. Like when we've had some major flooding, tornadoes, things like that. That may affect more of the homeless or the lower social economic status patients or families than people that are able to travel or have financial ways to get food. Inner cities, maybe not as necessarily as much here in Iowa and Cedar Rapids and things like that, but if we were to get to bigger cities like Chicago or New York, things like that, big super-sized grocery stores that have a wide variety of nutrition and choices of food are actually not as readily available. So in some of the cities, if you don't have the finances to travel by bus or train or car, and you're just relying on walking, that you may not actually be able to get to a grocery store, and so your source of food is actually coming from places like a convenience store. And of course, they don't have as many choices for you to access food. All right, nutritional disorders. There's all sorts of them that we can think about. Vitamin imbalances due to, so we want to do complementary and alternative medicine to help offset those things. So hopefully they're accessing healthcare to get the supplements needed to offset whatever is going on. So for instance, as we know, as we age, vitamin D and calcium are poor in our system. So what do we start recommending people do? Start taking those vitamins. So that's one way we try to offset those things. Same with mineral imbalances. Vegetarian diets. This is one that if you are a very picky eater or you don't have a good enough knowledge to recognize what foods have what kind of minerals and vitamins in them, protein, things like that, you may actually end up with a nutritional deficiency. So if you don't like green leafy vegetables and you just stick with some fruits and a very minimal amount of vegetables, you may have a poor diet. If you're not eating legumes and other sources of protein, then they are going to have poor protein in their diet. Some protein and energy malnutritions that our book mentioned briefly, and I thought were very interesting. We don't see these as much here in the United States, but honestly, in Iowa City, we are seeing an increase in people from other cultures coming in, so we may actually have patients that have come over that have dealt with these. Kwashiorkor and marasmus. So those are some things to kind of keep in mind. I want to say it's and I'm probably not saying this right, the marasmus, that it, they go by hierarchy in the families, and they make meals, and so part of this could be due to financial reasons too, but this is also their hierarchy that when they make meals, the parents or the adults eat first, then it comes to the next level of kids and then goes down from there. And then like the children eat last, and so the children get whatever's left. So if they didn't have enough protein made, then those children may not get the protein they need, or things like that, especially when it comes to their financial abilities or the access to the food. They may not have enough to spread it out between everybody. Okay, so food sensitivities and food intolerances. An intolerance means that you have an immune response, and you have just an intolerance to cow's milk, but other forms of lactose you can eat, or same kind of things, like you have a gluten intolerance versus a gluten sensitivity. So a gluten sensitivity means I can eat certain types of gluten, and every now and then I'll get a little bit of a reaction. But a gluten intolerance, which would be celiac disease, if I eat any form of gluten, it would cause me to have major issues. Okay. So there's a huge difference out there. I think there's a lot of people walking around saying that they have intolerances, but you catch them eating things and they're not having problems. Lactose intolerance, they can't eat any form of lactose containing products. No ice cream, no milk, no cheeses, things like that. All right, so scurvy and rickets. We do not see these as often in the United States, but we can see these, especially in certain areas of our country. And the fact that we do have, especially here in Iowa City and Cedar Rapids, we are seeing a large amount of people coming from countries where this could have already started developing before they come over. I think these are things to be very well aware of. Many of you may not stay in Iowa, and so you may see this in other areas. And so I think we need to be very well informed on these two major issues. Scurvy. Scurvy is that deficiency in vitamin C. And so the top two pictures on this PowerPoint are some signs of scurvy. They have some malaise, lethargy. We see these spots on the skin. You can kind of see those little reddish brown spots. Changes in their gums, bleeding, inflammation, their bleeding of the mucous membranes, like I mentioned, very pale skin. We could be seeing this in our homeless population, our lower socioeconomic status areas, maybe not as much in Iowa City, hopefully, but bigger cities, we could see this as well. So with scurvy, we want to make sure we're getting good vitamin C in these patients' diet, especially as young children when everything is forming. So think of all those meals that are good in vitamin C, your citrus fruits, even just vitamin C supplementation is going to help with this. Rickets is another thing we don't see as often here in the United States. It used to be more common, of course, in our older generations, so like my grandparents or even before that, due to like the Great Depression and things, but we could be seeing this in some of our lower socioeconomic patients, and in certain parts of our nation, and as people start to come into Iowa from other countries, they may have already started developing this. Rickets is the lack of vitamin D, calcium, phosphate, or sunlight. Our melanin in our system helps us or our lack of melanin in our system helps us absorb that vitamin D in sunlight. And so darker skinned people tend to have an increased risk for developing these vitamin D deficiencies. So that's something to kind of keep in mind as well. So some signs and symptoms that we might see: bone pain or fractures, that bowed legs that we see in these two lower pictures, dental deformities, so horrible teeth, impaired growth, cramps of their muscles, the bowed legs I mentioned. So some treatment for this is getting that calcium in their diet, phosphorus supplements, and vitamin D supplements. The reason why we don't see this as much in the United States as well is because we infuse vitamin D and sometimes calcium and different things in a lot of our food. So a lot of our cereals are fortified with vitamin D and calcium. Milk has vitamin D added, things like that. So that's one way we in the United States have been able to help prevent some of this. But once again, when we're looking at lower social economic areas where maybe they can't get as good of access to enough of that, we could still see this developing. And like I mentioned in the second slide, up near Alaska, we might see this more. There's some disorders that this is one disorder that we threw in that we do not know the true etiology of it, but it is something that we've wondered if nutrition plays a role, is colic. Colic is somewhat common in our infants, and they have this very cramping abdominal pain. So you'll see them pulling their knees up to their chest and crying and being uncomfortable. So some cramping, the crying 3 C's. So crying for greater than 3 hours a day, at least 3 times a week. Typically in the evening hour, and it could be for hours at a time. They say kids can grow out of this, and it typically is affecting kids under the age of 3 months. However, I have heard of the first year of life for some kids is they go through these colicky issues for a long time. So causes of colic, like I said, we don't really know what the causes is. We wondered if it's feeding those kids too fast, making them eat too much, allergies to milk, so those lactose intolerance issues, or just cow's milk, sensitivities, not burping enough, stress in the home. Excuse me. As we know, our infants have a immature central nervous system. And as that central nervous system matures over the first year of life, we've wondered if that helps decrease this cramping that is going on, smoking, things like that. Treatment. Well, we need to find the cause if we can. So if it's the milk issue, putting them on a lactose-free milks, or if mom's breastfeeding, sometimes we have her avoid all lactose containing products, and hopefully it doesn't cross through to the breast milk and that baby will be fine. If that doesn't do the job, then they do have to go on specialized formulas. We will use antispasmodics, like Mylicon drops. Lots of controversy on there. Some people don't believe they work. Gripe water, I believe it's GRIPE, is an old wives' tale that people have used, and it's still being used out there. I am not 100% sure what is in it, but they say having the baby drink a little bit of the grape water. Now, this is where I've seen some issues in blogs and recommendations by people as they're telling them to drink like an ounce or so of the grape water. If we are giving those babies an ounce of grape water, are they going to be eating enough of the formula or breast milk that they need to get the nutrition they need? It may not. So that could actually cause nutritional deficiencies. So if you're going to be using grape water and some of these old wives' tale type of complementary treatments, make sure it's a minimal amount. So only like 5 cc's or something, that it doesn't throw off their abilities to eat what they need to grow and have their brain development. Okay. Making sure they're burping more frequently, making sure that we're not overfeeding the babies. And this happens more often with bottles because formula is expensive. And let's say you mixed up 3 ounces and your baby only drinks 2.5. You try to force them to take the last half because it's not good after, the babies drink off of it. Things in mom's diet, spicy foods, different things like that. So mom sometimes has to change her diet if she's breastfeeding. Don't smoke around the babies. Making sure they're having good bowel movements and voiding. And if they're not, maybe we need to give them some things to help them stool more. Some people have used chiropractic care to help with colic. With chiropractic care in babies, it's not manipulating the joints and muscles like we think about in the adults. So where they're not cracking their neck and their back, they're actually doing more pressure points and a massage type thing. Reassuring the parents that it gets better and everything they're doing is great. This is when we talk about stop, put the baby down in a safe place if you're getting upset from their crying. Some people have said that just simple movements helps the babies with that abdominal pain. So putting them in bouncy chairs, taking them for a ride in the car. Now this is where we have to talk about that safety factor of making sure that baby's in his or her car seat in the right location of the car while you're driving, instead of like my neighbor used to do when I was growing up. Same time almost every night of the week. He or she, the husband or the wife, would take their baby and drive down the street. And what I noticed was weird was they would be holding the baby. What were they doing? The movement of the car and the sound of the car helps soothe the pain of the colic. But what's the safety factor in that? Car accidents, things like that. Why did they do it? Because the baby falls asleep and then they don't want to wake them up by taking them out of their car seat. Well, that's not safe. Car accidents, things like that. I've also heard stories of people putting the baby in their bouncy chair or their car seat on the washer and the dryer because the movement of the washer and the dryer helps. But what do we need to put in there? Make sure you stay with the baby and don't walk away because guess what could happen? Car seat fall. Make sure things that we think are common sense may not necessarily be common sense to others. So we need to throw in that, reiterating that safety factor. Okay. So growth failure to thrive. And hopefully you learned about this a little bit in Unit 6 and Unit 5. Failure to thrive categories. They need to fall below typically the 5th percentile. Some places will look at the 10th percentile on that growth chart, meaning the recommended average heights and weights for our population. Okay. And this is based on healthy weights, the ideal weights and heights. Okay. If they fall below that 5th to 10th percentile for more than one instant or continuously, then they will maybe start thinking about failure to thrive. So if they fall below this once, they may not worry. If they fall below it twice, they may just start asking questions. If they continue to fall below, then we need to really do some investigation. So failure to thrive can be caused to inadequate caloric intake, inadequate absorption, increased metabolism, and defective utilization. Okay, so what could lead to these things from going? So there's 3 types of failure to thrive. Organic failure to thrive or physical failure to thrive. This means we have a physical cause or a medical cause that is leading to inadequate absorption or intake, or a change in the metabolism, or their body's inability to utilize the calories they're taking in. So, for instance, cardiac issues. With cardiac issues, you have an increased metabolism or metabolic drive, which means that whatever you're eating is not going to be adequate for that baby to grow, or that toddler to grow, so they will put them on higher calorie diets. Renal failure, many other medical disorders could lead to issues with organic or physical failure to thrive. Another one is non-organic or environmental. This is also that psychosocial form of failure to thrive. This is unrelated to disease. So, decreased in maternal infant attachment. I read a research article one time, and now I'm forgetting, this was back when I was early on in my nursing career, that I can't remember if it was New England or actually England, in nun ran orphanage. They had 2 baby rooms, and in one baby room, the nuns would sit there and hold the babies and coo and caw at them during their feedings, and rock them and talk to them during their feedings. And the other room, during the feedings, the nuns would then just prop the bottles. These babies were getting the exact same amount of nutrition, but the one room was getting that attachment part and the other room wasn't. What they found is the babies that were given bottles propped, they did not thrive as well as the babies that were having some sort of physical attachment or maternal attachment to the nuns. So what did they do? Of course, they went back and started giving everybody enough attachment. So in those cases of neglect, abuse, and things like that, those kids may not thrive as much. Not getting good nutrition due to poverty, due to cultural knowledge, the stress in the environment, divorce, depression, parents are focusing on their children that are chronically ill. I'm trying to think what else. Changing of jobs, or moms, dads that are having to work multiple jobs, and so those kids aren't getting that well balanced meals. Just families stressed out because of finances, whatever. People don't eat as well. This could also lead to obesity issues too, but we're looking at growth failure. One thing that I've also seen is doing those health child rearing practices. So very strict feeding schedules. So you're only going to eat at 8 a.m., noon, and 6. Even if the child isn't hungry, that's the only time that they're going to feed them. So the child only eats at those times and they may not eat as much. Part of that is also only allowing them so many calories. So you're only going to eat this little bit, and that's all you get, even if you need more. Fad diets. Women and some men that are obsessed with fad diets, they actually start having their children do these fad diets, which then can affect that children's ability to grow. Back when I was in nursing school, there was a lot of people that were very obsessed with their weights, and we're still seeing it, that I would hear stories, and out in public I would hear it, these women that were minus zeros in weight, that hardly ate anything. They would see a baby or their own baby and like, oh, my baby's starting to get fat rolls. That's so disgusting. They're going to be fat as they grow up. So what do? They don't feed them as much as they need to grow. So they start putting their young children on the cabbage leaf diet or these fad diets that aren't giving that child the well-balanced nutrition they need to grow. Okay, this could fall into that abuse category. The last form of or type of failure to thrive is idiopathic or unexplained. And this is literally what it is. We do not know why the child isn't growing and isn't absorbing or isn't utilizing the calories they're getting. The parents are doing everything right. They are feeding the child like they should. The environment that they're eating in is very calm and appropriate. And there's no medical issue. And this child is still not growing appropriately. Okay. We do take into consideration also when we're looking at that height on the growth chart, what the parents are like as well. If you have two very tiny people, your child may not fall into that normal percentile. So we wouldn't consider that failure to thrive. All right, nutritional alterations. So those assessments, I shouldn't have to go through this with you guys, but I'm going to just hit some things. I know Nicole gave you guys a really good nutritional assessment and health assessment. I know you've gotten it in Foundations 2 and Foundations 1 and back in your nutrition class. But what are those things that we look at? Height, weight, recording everything that they're doing, skin turgor, looking at their tongue, looking at their clarity of their eyes, their hair, all of those things. The other parts we want to think about when we're looking at nutritional alterations is getting that food diary. So record of all intake and output, looking at that child-to-parent interaction, finding out what their environment is like when they're eating. Are they on the go constantly, or are they sitting down at the table, eating on the couch, whatever. And from there, we can work with psychologists if needed, social workers, the doctor, the nutritionist, and occupational therapist, whomever, speech therapy, to start making those changes needed. So some big things: consistent routine. So instead of always eating in the car on the go while the car's moving, trying to make time to sit down at a table and eat. So what can we do for this? Start helping the parents with meal planning and planning well-balanced meals. Quiet environment. Those toddlers, you've probably seen it out in public. Toddlers, if there's noise and distractions, what are they going to do? They're going to pay attention to the noise and distractions versus eating their meals. So making sure we have that quiet environment, eating at a table versus on the couch in front of the TV, making sure it's a calm environment, structure and routine that is positive and not restricting. So yes, that might be some consistency on making sure we're eating at similar times of the day, and we have a routine going on that is not chaotic to eating. So babies that are struggling to be consistent with bottle feeding, that's putting consistency on the type of bottle we use, the type of technique we use when we're holding them, things like that. All right. Distribution of body fluids. So, this is looking at your intracellular, extracellular, your body, total body water, maintenance water requirements, and altered fluid requirements. So when we're looking at this, you don't need to know how much fluid intake the child needs, and then the fluid rehydration formula. You'll learn that in Advanced Concepts of OB-Peds, hopefully. This is looking at that intracellular versus extracellular fluid, and this is very important when looking at weight and hydration of our kids. Weight is a reliable indicator of fluid volume in pediatrics, especially the younger the children. Also think about children have more extracellular fluid percentage and an increase in body water compared to adults. Adults have more intracellular fluid. Okay? So because kids have more extracellular body fluid, they are going to be at a higher risk for dehydration because they're going to lose that faster. Okay? Just making sure I'm not missing anything. Okay. So we have very multiple types of dehydration. You don't need to know all the different types of dehydration or degrees. Just recognizing that we have acute versus chronic is the biggest things. There's different diagnostics for evaluating dehydration. We'll talk about those. Parental fluid we'll talk about, and different nursing considerations. So some clinical manifestations of GI dysfunction. Trying to think about where I'm at in my notes off the top of my head. I apologize. Ability to thrive, we've talked about. So that's impaired function. Spitting up and regurgitation, which is very common in kiddos, or in infants, but we'll learn about in a few slides a couple different disorders that could lead to major issues with that. As you've learned in the adult world, GI losses and fluid absorption disorders can affect these kids. So nausea, vomiting, diarrhea. We'll talk about diarrhea here a little bit. And then we have those inflammatory disorders like Crohn's disease, liver failure, and fever. You've talked about these in the adult world. We are not going to go into those in the pediatric world. All right, diarrhea. That's such a fun word and fun topic. All right, acute diarrhea is one of the leading causes of illness in children under 5 years of age. We see this less often in developing countries, but 20% of deaths are related to diarrhea and dehydration. And there's a lot of acute infections with diarrhea that are caused by different organisms. We're actually seeing a huge widespread of rotavirus across the nation, and many schools are having to close down due to a high number of kids passing or being ill due to rotavirus. So we have acute versus chronic diarrhea. You don't need to focus as much on intractable or nonspecific. So acute diarrhea. This is diarrhea that lasts less than 14 days. Some of the causes of this could be infectious agents like rotavirus, upper respiratory infections, UTIs, the use of antibiotics. Typically, you're on antibiotics for less than 14 days, and as we know, antibiotics can lead to diarrhea. It is something that doesn't last long term. Remember, diarrhea is abnormal intestinal water and electrolyte transport. Okay. Chronic diarrhea, it lasts greater than 14 days. These are your malabsorption issues, allergies, lactose intolerance, celiac disease. If they are not following their diet, can lead to chronic diarrhea. Inflammatory bowel disease. I would say also with chronic diarrhea, it becomes more chronic in other countries because they don't have good clean water supplies and they're constantly being affected by causative organisms. Excuse me, I can't talk this morning. So, disorders of motility. So once again, what are some of those causes of that diarrhea? Rotavirus I mentioned earlier, which is spread fecal to oral. And that is typically how diarrhea is developed. A lot of these fecal oral route or contaminated food or water, person-to-person contact. So poor hand washing, no clean water, crowding, lots of people living in a small space, not good sanitation. Okay, rotavirus, it's viral. This is very rampant in daycares because of why? Babies stick their hands in their pants. Toddlers stick their hands in the pants and they don't wash their hands and they're touching everything. We also see this in winter, seasonal times of the year because of lots of crowds, people touching everything, coughing, spreading things, poor hand hygiene. There's a vaccination for rotavirus. Hopefully this is not a big new topic for you guys. You should learn this in Unit 6. That is given at 2, 4, and 6 months, and it's the only oral vaccination we give. We have bacterial causes like Shigella, Salmonella, and E. coli. These are passed by food contamination, but also water as well, and it can be spread by fecal oral. We have Giardia, which is a parasite. So what's going on? We end up getting exposed to the cause of these microorganisms, and our body then starts producing enterotoxins that then stimulate the secretion of water and electrolytes. And so then we get, in pediatrics, because of that extracellular fluid in their system, they're at higher risk for that fluid being pushed out and secreted and dehydration being caused by the diarrhea. And then we end up having a direct invasion and destruction of those epithelial cells as well. These kids can get a lot of inflammation locally, and adults. So what can this lead to? That dehydration I mentioned, severe fluid and electrolyte imbalances, which then could lead to shock, such as hypovolemic shock. Hopefully we can catch it before it gets that far. So how do we prevent diarrhea from occurring? Well, good hand hygiene and showering. Washing our hands after going to the bathroom and washing our hands after preparing foods. Meat products being prepared on one surface and not preparing non-cooked or other foods on those same surfaces. So we should typically have cutting boards for just our meat products and cutting boards for just our vegetables and fruits. Because even though we've washed our cutting boards for our meat, That may not become because they're porous, and the dishwasher and our normal washing of things doesn't always get into those little cracks, and they can still be there on those non-cooked foods. I never would use a wood cutting board. Storage of food after it's cooked, things like that. Washing our hands. Cleaning of water and not drinking dirty water from streams or puddles and things like that. All right, so dehydration. What causes dehydration? Colds, microorganisms, things like that. I mentioned that children are at high risk because of their increase in extracellular fluid and less intracellular fluid. They have an increase in insensible fluid loss due to their increase in body surface area. They have an increase in their beta metabolic rate, or their basal metabolic rate, and they have immature kidneys. This is where we will see that specific gravity being a lot different than in the adult world. It's 10:01 to 10:20 or 10:30 for the urine concentration. So they're at higher risk for that insensible fluid loss due to that increase in the body surface area. And how do we lose fluid through our body surface area? 2/3 of that fluid is lost through our skin and 1/3 through our respiratory tract. And think about it, kids have more body surface area of skin area than adults compared to their size. Their increased BMR means they have increase in oxygen consumption, which means they also have an increase in waste products to be excreted by their kidneys. However, those kidneys are immature and they're inefficient at excreting those waste products due to metabolism. So they're not able to concentrate their urine or dilute it. So they have issues with both concentrating and diluting. Which would in turn help them save H2O like we can as adults. They're not able to conserve or excrete sodium appropriately, which also is that talk about how we, that sodium potassium pump and in keeping our fluid balance well. So they struggle with that. And then they have very acidic urine. So all these things put our kids at higher risk for dehydration. So those symptoms of dehydration, I know you've learned this in health assessment and other courses. We're going to go over it again. Some of these are the exact same things that we see in pediatrics. So that poor skin turgor. Now, skin turgor isn't always the most reliable. One of the best areas to check it is on the abdomen just below the ribs. We will also sometimes check it on the clavicles. Okay. They're probably checking it a little low in this picture. Cap refill, weight, tachycardia. If they still have a fontanelle, so under the age of 2 or 2 and under, you should still have one of your fontanelles. You can feel that. And if it's depressed, it's dehydrated. Sunken eyes. Those dry mucous membranes, that dry furrowed tongue, lack of tears when they cry, looking at their urine. Granted, it's not the most reliable indicator, but you can still get a little bit of an most reliable way to look at it. But we know their urine concentration is off, so if it's severely different than that 10:10 to 10:20, 10:30, then we can be like, okay, we have an issue here. Their urine output, 1 to 3 milliliters per kilogram per hour. Okay, 1 to 3 milliliters per kilogram per hour. Where an adult is 30 to 60 milliliters an hour. Let's see, not having as much urine out. Not changing the diaper as much. I'm trying to think what else. changes in their blood pressure, vital sign changes. Okay. So how do we diagnose these disorders of motility that led to their diarrhea, and then led to their dehydration? Stool cultures. Okay. We can look at enzyme-linked immunosorbent assay, ELISA. Now look, ELISA is also used for other tests as well, but this one is going to specifically look at things like rotavirus and giardia. We're going to look at C. diff, especially if that child is on antibiotics. And if that child tests positive for C. diff, what are we going to give them? Flagyl and vancomycin. We can look at their BUN and their creatinine. We're going to look at that specific gravity, okay? Recognizing that it's different than the adults. We're going to look at their H&H, their hematocrit and hemoglobin, okay? All of these are going to be decreased with dehydration, okay? Okay, so what do we do when their kids are dehydrated? We're going to give them oral rehydration therapy. One form of oral rehydration therapy is Pedialyte. We're also going to assess for these fluid and electrolyte imbalances. Okay, we're going to rehydrate them with some sort of oral rehydration therapy. Preferably, like I said, orally. We're going to give them small amounts frequently throughout the day. Okay, versus giving them an 8-ounce glass of water every 3 hours and telling them to drink that 8 ounces right then. They're not going to be able to do it. Slowly reintroduce diet. Okay, cleaning, things like that. If they're not able to use an oral rehydration therapy, which hopefully they can do this at home, then they're going to be admitted to the hospital and get an IV. Okay. Pedialyte is great because, or other forms of oral rehydration. I know there's more than just Pedialyte out there, but this is the most common. These help to reabsorb the water and sodium, which therefore in turn will help decrease the amount of vomiting and decrease that volume loss from the diarrhea. And hopefully that in turn will decrease the duration of their illness. Once again, this is going to go back to that education of how it's spread and having good hygiene. Making sure people have access to clean water supply. Preparing food adequately and cooking things adequately. Hand washing, things like that. Pedialyte is actually good for not only just pediatrics, for adults when they're dehydrated. When adults have had their binges of drinking too much, you get severely dehydrated. You should actually drink some Pedialyte while you're doing this. Pedialyte is better than Gatorade or Powerade because those have sugar. And actually sugar in turn will make the diarrhea worse. So try not to give kids, when they're dehydrated and sick, things with sugars in it either. So we typically do this on a 1-to-1 basis. So every 1 cc of loss, we should replace it with 1 cc of fluid. We also have a formula that's talked about in your book. Like I said, you guys don't need to know that right now. Small, frequent intervals. So some ways that we can do this is we can make it a game. Every hour, go into the patient's room, give them about 5-10 cc's or whatever the amount they're supposed to get within 24 hours. Spread it out throughout the day per hour and go in there and be like, hey, let's drink this together and see who can drink it faster. You, as the nurse, may only be drinking water or Sprite, whatever. Just make sure the kid can't tell it's different than what they're having. And you can have a chugging contest. You can make a game out of it, that kind of thing. If they can't get it in orally, we can put an NG in or a G tube. That would be like severe cases, or an IV. Okay. Gastroesophageal reflux. This is different than the GERD you learned about in the adult world. This can lead to GERD, but kids or infants don't typically develop GERD. Gastroesophageal reflux is due to the immaturity of the esophageal sphincter that is right at the bottom of the esophagus and entering into the stomach. This sphincter is kind of weak and allows for a delay in the gastric emptying, or in fact, if they get too much in their stomach, that pressure presses up on that sphincter, and that sphincter will just relax easy and allow that fluid to come up into their esophagus. It's not comfortable if you've ever had any reflux due to overeating or whatnot, and it's not comfortable to these kids either. These kids may spit up a lot. They may have weight loss if it's severe. They may have some failure to thrive, especially if it's severe and they're not eating well and puking a lot. They may cry a lot because it's uncomfortable and it hurts. GERD is the tissue damage that can occur in adults due to the reflux. Okay. GER is just the reflux, and in kids typically does not develop into GERD. All right, so how do we manage GER? Some of it depends on how severe it is. If they're thriving and they're not having any aspiration or respiratory issues or pneumonias due to it, our treatments are going to be less invasive or intensive. About 85% to 90%, somewhere around there. These kids typically outgrow it within their first year of life. And so it may just be as simple as positioning them when they're eating. So keeping that head of the bed high. There's lots of new research out there that is stating that they should be at a 90-degree angle for around an hour after feeding. Well, in infants, putting them in a bed at a 90-degree angle, actually their head's going to relax and close off, and that could actually cause major issues in them because their head's going to roll forward and close off their airway. So we actually tell the parents to hold them for that hour at that 90-degree angle. If they can't do it for 30 to 90 minutes, we tell them to just keep them flat, because anywhere between below 90-degree angles we have been finding really doesn't help. Smaller, more frequent feedings, because then you're not having as much stuff in that stomach that's going to push back on that sphincter. They may trial some other formulas. We will do H2 antagonists like Tegament, Zantac, Pepcid, gastric pump inhibitors like omeprazole or Prilosec. Okay. In severe cases of failure to thrive, and if they're having a lot of aspiration leading to pneumonias, and other inflammation of their esophagus or major issues, we'll try G-tube feedings so that the food is not going into their stomach and they're going below there into their intestines. Another thing we might do is do a Nissen fundoplication. Nissen, like Nissen, fundo, Fundo, plication, Plication. So fundoplication is one word. What we do is we take, as you can see in this picture, we take the fundus of the stomach and we pull it up and wrap it around that lower part of the esophagus and suture it closed. These kids will live like this for the rest of their life. If it fails and comes unsutured or overstretches and goes back to where it is, they won't do anything about it as long as the child isn't having issues. What this is doing is actually, part of it is causing compression around that sphincter, but it's also changing the way the stomach is laying. The smaller they are, the more compressed everything is in their stomach or in their abdomen, and that stomach actually lays more sideways. And as they grow and more space comes in their abdomen, that stomach actually starts to, instead of laying sideways, it starts to angle downwards a little bit more, as we can see in the drawing. And that actually helps with the gastric emptying, and therefore we don't have as much fluid backing up. So by changing the positioning of the stomach, that also helps with that fluid backing up. That is one of the reasons why kids typically outgrow it, is because as they grow, they have more space in their abdomen, and that allows for the angles to change for gastric emptying. All right, obstructive disorders, hypertrophic pyloric stenosis. The pylorus muscle, or the pylorus, is at the bottom of the stomach, where the stomach connects to the duodenum. This pylorus muscle thickens and causes severe narrowing between the stomach and the duodenum, and it doesn't allow for that fluid or feeding to leave the stomach to go into the duodenum. So severe edema, inflammation, and it can lead to an obstruction if it's closed completely off. So what happens as that baby eats, that food has no place to go. This develops during the first few weeks of life, so we don't always see it right after birth. So nice, healthy babies will go home, and then mom and dads will come back somewhere between the ages of 1 week to 10 weeks. Usually it's within the first month, and they'll start saying that their baby's puking a lot, and we're going to start noticing that they're not growing because they're not getting any absorption of their food. And the parents will say that their child is having projectile vomiting, which occurs within the first 30 minutes to 60 minutes after feeding. And projectile vomiting is different than normal vomiting. Normal vomiting will kind of go out a little bit further than their body, but projectile vomiting, it'll fly and it'll be forceful. I was feeding a baby one time and it went across the room. So it really flies. It's really projectile. These babies are going to, of course, act very hungry. That vomiting or emesis is going to be stale milk. There's going to be no bile because it hasn't gotten to the bile containing part of their digestive tract. Let's see what else. As the nurse is doing her good abdominal assessment, she's going to be feeling along that stomach, and she may feel just to the right of the umbilicus, palpating a mass that is about the size of an olive, like a black olive or green olive, and it's going to be kind of a hard feeling. That's that inflamed pylorus muscle. If you're looking at peristalsis, you might notice that the peristalsis goes from the left to the right. That child is going to have signs of dehydration and lethargy. What else have I seen in these babies? They're, of course, going to always act hungry. It's typically seen in Caucasian infants. It's typically first full-term infants. We catch it faster in preterm infants. It's more common in males. Hold on a second. Let's see what else. Firstborn babies. There has seen some reoccurrence in siblings. So there might be a genetic link to this as well. All right, so the treatment of pyloric stenosis is surgery. But before that baby can go to surgery, they're going to be severely dehydrated. So before we go to surgery, we're going to re-establish hydration in these children. So how are we going to reestablish hydration in these children? We're going to put an IV in. So they need to have intravenous IV fluids before they can go to surgery. We're also then going to make them NPO. Hydration comes first through their IV, then NPO. Okay. We're also going to do an ultrasound and maybe an upper GI, and that's going to help us find the narrowing and prove that this is what it is. Then they're going to do the pyloromyotomy. So they're going to open up the pyloric muscle to allow for the fluid to empty. This can be done laparoscopically now, but they may also do full open surgery. Let's see. They like to do the by scope or laparoscopically because, of course, it's shorter surgical time and that baby gets back from surgery and is able to start feedings quicker. After post-op, after surgery, we're going to watch that baby wake up from anesthesia. Once they're fully woken up from anesthesia, and hopefully the parents are at the bedside, we will start them on oral rehydration fluids like Pedialyte. The first few times is probably going to be done by NG. And then they may start allowing them to PO feed it. So this may start around that 4 to 6 hours after surgery. Excuse me. So about 4 to 6 hours after surgery, when that baby's fully awake, is when they may start those fluids by NG or orally. As they're tolerating the oral rehydration therapy, also maybe Pedialyte, as they start tolerating a little bit that way, then they might do a half and half mixture. Half of the oral rehydration therapy fluids, half breast milk or formula. And as they tolerate for several feedings the half and half mixture, then they'll move them to a full mixture of breast milk or formula. They'll also slowly increase the amount that's going in of those feedings. It may take 1 to 2 days or about 48 hours for them to totally tolerate full feedings. This is not an outpatient surgery. Typically, they usually be observed for at least 24 hours post-op to make sure the feedings are going okay. And then they may be sent home and given those directions of how to increase those feedings. It may be 1 to 2 days before they're up to that full amount of feedings that they were taking before. Right. Oral candidates. Hopefully you guys know what this is. This is thrush. White plaques on the oral mucosa, gums, and tongue. Babies will have white film on their tongues. That's actually formula or breast milk. If you can wipe it off, that's what it is. If you can't wipe it off, then it's thrush. This can be very painful to the kids, and therefore they may have poor intake of their feedings. It can also be caused due to from mom to baby if they're breastfeeding. If mom is on antibiotics, she may be developing candidiasis. and be passing it to the baby through her breast milk. If baby develops it and mom doesn't, and she's breastfeeding, we'll treat both baby and mom. If baby's on antibiotics, she may develop it as well. This can also be caused from dirty pacifiers, not cleaning of bottles or breastfeeding devices. So if mom's pumping or she's using breast shields, different things, if those things aren't clean, the thrush or the fungal infections will build up and cause candidiasis in the baby and or the mom. So some ways to help prevent it is, if mom and baby are on antibiotics, just going ahead and treating, especially if they're breastfeeding, treating both with nystatin. If baby's just bottle feeding, just really good cleaning of bottle equipment, boiling things in hot water or sterilizing things. Same with the pacifiers. Mom's breast pumping and any assistive plastic devices or anything that she may be using on herself, changing out the breast pads, things like that more frequently, to help decrease the fungus that could be developing. An over-the-counter remedy is turmeric. You can mix turmeric with a little water and swish it in the mouth, I guess. Babies aren't really good at the swishing part. You typically give about 2.5 to 5 mils. If ever, it's been a couple months since I've given it. 5 mils is about what I usually have given to some of my infants. You can just pull it up in a syringe and put it in their mouth, and give it to them by a syringe. But what I have found over years of practice is it doesn't coat the whole mouth. That just kind of gets a little bit in the mouth and then it goes down into their throat, which is great. But that thrush builds up all over and coats the mouth. So using those oral swabs, those pink oral swabs, or there's some green ones that are smaller, and measuring out your 5 mils or whatever the amount is and absorbing it into the swab and really rubbing it on every surface of the baby's mouth and then letting the baby suck on it gets that mouth really good and coated with the nystatin. Once again, remembering not to feed the baby right after giving nystatin. So if the nystatin dose is due with a feeding, feed the baby, then give the nystatin. Okay, obesity. This should be our last topic. Obesity, I don't feel, is very well covered in many of our books, which is sad because obesity is becoming one of our biggest problems in our nation, not only in the adult world, but definitely in our pediatric world. All right, so obesity is defined as an increase in body weight due to the accumulation of excessive body fat related to lean body mass. We typically consider you obese if, when you're looking at that growth chart, that the child is falling more than the 95th percentile on that growth chart for their age, gender, and height. Overweight is when they fall in that 90th percentile. Okay. What was it, about 5 years ago? Maybe it was in the teens for the amount of children that were considered obese. Our book came out a couple years ago and it's saying somewhere between 25 and 30%. Okay. It's gone up even higher than that, I'm sure. Another thing when we're looking at obesity and those growth charts, and remember with the growth chart, that is the ideal weights of people, and is based on what is considered healthy weight for people, okay? And what is our nation doing? So many more of our nation is not falling in those categories, okay? So, what was I going to say? Now I lost my train of thought. Oh, we're looking at also with the height and weight is the parents too. So if you have parents that are in their 6 foot range, high 5 foot range, that could affect where that child's going to fall on that scale too. So that's something to take into consideration as well. All right, so obesity, there's lots of relationships in obesity, as we all know. We have that genetic predisposition, we have metabolic diseases and variants that can affect this, that family habits, cultural habits, okay? All of this can lead to obese infants and obese children. This graph, I think, is off a little bit because of our culture and our society and way it's working now. It's saying obese children also have some of those psychological pain that's leading to them to deal with that pain in inappropriate ways. So eating, overeating to relieve their pain and their depression, the guilt and shame. We're actually starting to see some of this in our children, our school-age kids. Okay. There's also having metabolic disturbances and increased weight, and it's just this continuing of a circle. Okay. And we see it in our adult population as well. We're seeing an increase in type 2 diabetes. They used to say type 2 diabetes didn't get diagnosed until like adolescence. We're starting to diagnose younger children with type 2 diabetes as well. Which is kind of sad if you think about it. This type 2 diabetes is what supposed to be our adult onset diabetes, and we're starting to diagnose our young children with this. And it's very hard to get off of those medications for diabetes once you're on them. We're also seeing hypertension, hyperlipidemia, and cardiovascular disease in our children. My mom's a preschool teacher. Well, this is her last year, but anyways. And she has had a preschool child. Oh, how many years ago has it been? Almost 5 years ago, maybe now. That was 90 pounds. And she was wearing the same size clothes as my daughter, who was, I think, 5 years older than her. And this little girl would get up from her chair and only be able to walk a few feet without having to stop and breathe. And she would just sweat, and she would just be fatigued. She was being treated for hypertension. This was a preschooler, you guys. Okay? We're seeing these issues in our young children that are supposed to be adult things due to our obesity epidemic in this world. Okay? These kids become social isolated. They end up having low self-esteem and depression. Okay? Causes of obesity, sometimes it's disease related and genetics related. But a lot of it is the way we eat, the type of foods we eat. What's cheaper to families is not nasty food, but not healthy food. Okay? And that's a problem, because what is it leading to? The obesity epidemic. Okay? The pattern of eating in front of the TV, eating on the go, and what are the easier foods to eat on the go? The not healthy food. We're not as active because our environment is not as safe for these kids to be as active as we would love for them to be. All of these things are contributing to these problems we're having with obesity. Okay. Diagnostics. Big diagnostics, of course, is going to be the height and weight checks and looking at where they're falling on the growth chart for their recommended for their gender and age. But we also will look at skin folds. We will look at body mass calculations, and we'll also look at diagnostics to rule out metabolic and endocrine disorders. So if it's a thyroid issue, we'll want to get that fixed. If it's a few other issues, we'll focus on that to see if that helps with the child and their weight. Okay. All right, so what are we supposed to do? How do we help this epidemic? A lot of it is going to go down to our assessment and finding out what the causes is and what's going on in that home. Their knowledge, financial, and their ability to access good nutrition. What else are we going to look at? Their activity level and what they're doing to stay active and how we can help increase activity. What else? I'm trying to think. So where are we doing? What are we doing for this? Well, Michelle Obama had set up some really good things. There's still some controversy out there related to meals in the schools and getting healthier meal choices. One of the big changes that she helped with was vending machines in schools. Vending machines in schools typically were unhealthy foods. So a lot of schools' vending machines, especially the younger the age of the students in the school, are only supposed to have healthy alternative choices versus having lots of the sodas and chocolatey candy type options. And it's supposed to be healthier choices. So that's made a big impact. The school lunches are supposed to be better balanced meals. Some say they're not as don't taste as well. I don't know. What else have we been seeing? Well, one huge thing is children are supposed to be getting like an hour to 2 hours of exercise a day. And we used to get almost half of that in school. So you used to get like a half an hour of gym class, and then recess used to be 20 minutes. The lunchtime recess was somewhere between a half an hour and 20 minutes, and then you might get another small recess somewhere in there. And gym class used to be every day. Well, now that's not happening. Recess is maybe, in some schools, is only a couple times a week. Some schools it might be 3 days a week. Some schools it might be 4 days a week. The only recess kids are getting is during the lunch hour, and it's maybe 15 minutes. And I want to say gym class is shorter too than it used to be. So these kids are not getting the exercise at school that they used to be getting. But then when they get home, their environments aren't necessarily always the safest for them to get exercise. Excuse me, I apologize. So their homes, they go outside, and it's not safe for the kids to be running around outside because there's drug dealers, or we don't know our neighbors as well as we used to, and therefore we don't know if somebody's also helping us keep an eye on our children. And because of the increase of child abductions and different things like that are happening, our environments aren't considered as safe, so we don't let our kids outside to play. So they're not running around the neighborhoods and getting all that exercise out that they used to. And they're becoming more sedentary, playing video games, watching TV, things like that. Some of these homes and kids are living in apartment complexes, and therefore they're not able to exercise in their homes and make loud noises without the neighbors complaining. So how do we get exercise into their lives? Well, we can't take them to the parks because that's where the drug dealers are going, right? So getting them into programs that are going to be considered safe programs like the Y, before and after school programs, and helping figure out ways to, if it's a financial hindrance, that they can financially afford to put their kids in these programs. Helping them find ways that if their child is at home, that they can exercise. So, yoga. You know what? With video games, really Wii Fit is better than nothing. Having them play Wii Fit, having them play some of those interactive games where they're going to be moving, running in place as long as they're not making a lot of noise on the floor, jumping jacks. When you're cleaning in your house, having the music blaring, and instead of just walking around, dance. Things like that. Also part of it is getting healthier diets to our children. So not only getting them to eat healthier at home, but having them eat healthier at school. So getting that education out to the parents, helping the parents figure out how to meal plan, helping them find resources to get healthy foods. WIC for children 5 and under and pregnant women can help them get access to extra healthy foods. Same with food stamps, or the food EBT cards, whatever they're called nowadays. Now, what else is out there? Schools are starting to collect money or food donations, and they will send at-risk kids home for the weekends with bags of food, so they're not missing out on food during the week or during the weekends. Last winter, when we had several days of cold and kids were missing tons of school, some of the schools beforehand were collecting food donations and sending that home so those kids had access to healthy food when they were at home for those days that school was canceled. Just finding ways to do this. Education is key, and maybe making changes with how we are able to get healthy food. Aldi's has a really good priced veggies and fruits that are healthy. Hy-Vee will have near expired foods, or foods that don't look the greatest in their veggie aisle, but they're still good. That if you're in the store shopping with your young children, you can go to a basket and it's free fruit or veggie that you can just pick and give to your child. So maybe a banana that's a little bit more bruised, or an apple that's a little bit more bruised, or whatnot. So they can get some healthy food that way. Trying to think of some other options. Food banks, crisis centers, just helping our families be well involved. So when we're looking at the risk factors, we have to look at everything. Is the child sedentary? Are they eating a lot of fast food? And where they're at on that BMI or that growth chart. And those kids we may have to focus on a little bit more than that child who is maybe getting a little bit more activity and is getting a little bit more food or healthy food choices, and looking at the comparison that way. We will do medical therapies, pharmacological therapies in children as a last resort. I've been starting to hear about doing those major weight loss surgeries with kids are starting to happen to our teenagers, and our older school age kids because of how severe our epidemic is. And those things should be last resorts and only for adults, but this is the way our society is going. All right. If you have any questions, feel free to email Margaret and I, and hopefully we can answer what you need. This is all. Bye.